Very good evening, friends. We welcome you all to the Deccan Positive Mental Health. I welcome Kalyani ma'am. She is the special educator from Hyderabad. We are conducting this program from Manasha Shubhakara Mind Care and association with Yellow Pond Counseling Center, India, then Forest Creative Arts Studio from Punjab. We welcome you all. Now I am handing over the session to Sudha ma'am to give introduction about our today's resource person. Yeah, ma'am, please go ahead.
Thank you, Sunanda. I'm pleased to welcome, introduce Kalyani ma'am. Actually, she is incidentally happened to be my husband's cousin. So I'm inspired by her in many ways from doing the course also. She has done her master's in psychology, B.Ed in special education, PG diploma in guidance and counseling, and so many other courses. These are the main qualifications I would like to mention because she is into this field for so long, almost 14 years of experience she has in teaching. She worked at Future Kids School for 14 years and now presently she is working with Ganges Valley School as a school counselor. And she has attended and she has trained many teachers during her tenure at Future Kids, as well as now she is continuing the same thing at Ganges Valley. And she has attended number of workshops and many. I should say that I am inspired by her. I'm very eager to listen from her. Over to you, Kalyani. Go ahead.
Thank
All
you
the
so
best.
much. Thank you so much, Sudha, for that introduction. Ma'am, may I start?
Yes, ma'am, please.
Good evening, everyone. Thank you so much for this opportunity. Uh, I would love to, share my this thing here. Presenting my screen. Actually, I like this topic because it's a very application oriented therapy which can be applied just like CBT. It is an extension, actually it's an extension of cognitive behavior therapy, and it was originally started for the for behavior various behavior disorders, mainly borderline personality disorder. So DBT is a modified type of cognitive behavior therapy, and its main goal is to teach people how to live in the present moment, develop healthy ways to cope with stress, regulate your emotions, and improve your relationship with others. So it could also be used as a preventive therapy. So that it's very application based, very client friendly. So that is why I took up this topic. It was developed in the late 1980s by Dr. Marsha Linehan, and when they discovered that CBT was a little bit limiting to certain disorders like borderline personality mainly, but now it's being applied to a lot of other disorders also. So she is the lady. She's an American psychologist and author who has developed uh, dialectical behavior therapy. Now, I would like to know, I mean, just before I start, how many of us are applying this therapy? If anybody, is applying, could you just type in the chat box, please? If anybody is, applying this. Okay. I have not got any responses in the chat box. Anyway, DBT can be applied for mainly for borderline personality disorder, bipolar, GAD, generalized anxiety, OCD, ADHD, depression, eating disorders, suicidal ideation, substance abuse, and PTSD. So there are many. It's the applicability is very wide. So that's why it's preferred, and it's a very positive kind of a therapy. So it is very useful, and we will see the benefits of it. Now, yeah, many of us have this question as to what is the difference between CBT and DBT. So CBT mainly focuses on how, about your thoughts and feelings and how to change them, how to have alternative thoughts. So basically, a CBT therapist would, if a therapist is using CBT, they would work on the negative thoughts and changing, helping the client, look at alternative positive thoughts. So, and this is CBT is mostly used for anxiety, stress, and depression. Of course, other things also, but mostly for these things. So, but DBT has been found to be more helpful in dealing with OCD, borderline personality disorder, and suicidal ideation, many other applications. DBT often is the most effective therapy for those who struggle with self harm, cutting, and suicidal ideation. So, so that is the difference between CBT and DBT. If you have any questions, I can take at the end of the session. So how do we do DBT? There are three main settings in which we can do. Like, it could be done as a group therapy, because it has mindfulness and other things which can be done in a group. Then it could, and you could do it individually as an individual therapy. It could be done like that, or through phone coaching, means like over the phone. I mean, initially maybe you could do an individual therapy, and then you could follow it up with through phone calls and all that. So all this can be done. It is possible. Like, you could even do an online sessions for your client. So it is very flexible. DBT is very flexible. You can do it in different ways. Group therapy also works for in certain cases. So it depends on the case, of course. Then benefits of DBT. Now, how does DBT really help? uh, it helps in it helps the client by, you can help the client accept, first of all, the condition, and slowly bring about changes. So the behavior, you'll learn to analyze problem. You'll be actually equipping the client in making changes to analyze the problems and the destructive behavior patterns, okay, which could be replaced with healthy lifestyle changes also you can make. So that is what that's how it benefits the client. Then slowly, the cognition could be improved. Then they can, when they work with others, so they could collaborate with each other, they learn from each other. Then you could equip them with new skills to uh, cope with the disorder and make changes in their lives gradually, and lead more healthier lives. So how does it work? In DBT, the patients and the therapist work together to resolve the apparent contradiction between self-acceptance and change, to bring about positive changes. So basically helps them to cope with the resistance. Initially, there could be a little bit of resistance to acceptance and change. There could be denial. So gradually, but as start working with the client, and gradually they will see how it is going to help them. Once they see the benefits, they are more cooperative. So it becomes more like they cooperate and less likely to experience distress at the idea of change. So basically, we help them accept and bring about the change in their lives to be mentally more healthy. In practice, that therapist validates that an individual's actions make sense. See, initially, you might validate, say, okay, fine, you're feeling like this. It makes sense to me. It's maybe natural. Then gradually, you bring about, the changes in their this, and show them that how whatever the behavior is or the thoughts are counterproductive. So there'll be change, there'll be self management and acceptance, everything put together. The four major components of DBT are, so what are the main techniques, or what are the components of DBT? DBT has a mindfulness, first thing, emotional regulation, distress tolerance, and interpersonal effectiveness. So these are the four aspects of DBT which are used. So mindfulness, so I'll go through each one of them in detail, and also the application in case of OCD as an example. So mindfulness, as many of us know, is being conscious, living in the present moment. So you pay attention to what is happening at that point of time, instead of thinking about the past or the future. And you need to be aware of all your senses and how they are impacting you at that point of time. So this helps us pay attention to what is happening. You become more aware and conscious of your thoughts and actions. So mindfulness is a very strong tool of DBT, which really helps. So of course, we need to be trained in mindfulness to help your client. We need to practice ourselves before we actually help the teach the client how to practice mindfulness, but it is not very difficult. It can be done so I'm sure many of us are already doing it. So what's happening around you, so what you see, and you become conscious of, use all your senses effectively to to be in the present moment. Next is emotion regulation. Once you become conscious of your emotions, you will learn to regulate them. So the skills you learn will help you identify, name, and change your emotions. Like suppose I am scared at some point, about something, like I'm maybe scared to talk to people, or so once I become aware, I will be able to figure out how I can change that, or how I can cope with that. What are the strategies I can use? So emotion regulation is a very important and thing in DBT. So it reduces your vulnerability. I mean, you start becoming better at coping with it once you are aware, and you are equipped. The therapist will equip you with the techniques and strategies to cope with how to handle your emotions and how to regulate your emotions, so that you're not stressed. Okay, next one is distress tolerance. So any or most of these disorders are involve a lot of distress. I mean, a lot of or most of these disorders linked to this. I mean, there's a lot of distress. So you need skills to help you cope with those. Whether it is OCD, whether it is generalized anxiety disorder, PTSD, all of them, there's a lot of stress. So to overcome that, first of all, you have to accept yourself and the current situation. So DBT teaches you several techniques for handling all these how to get over stress is by doing when we think about what's going to happen or what's not going to happen. Thinking of if it's going to help you, what I'm thinking is you become aware of your thoughts, and whatever I'm thinking right now, is it going to help me in any way, or is it being counterproductive? So distress tolerance techniques help prepare you for intense emotions, and in emotions like fear, anxiety, anger, to cope with them in a more positive long-term outlook. So you follow things which are calming, more soothing, so that you can handle distress. Now, interpersonal effectiveness is about the relationships you have with others. So, which is very important because interpersonal relationships could be both positive and negative. Like it could affect us positively or negatively. So how to handle that? So interpersonal effectiveness helps you to become more assertive in a relationship, so that, like, suppose you're angry with somebody and venting out. So instead of saying negative things, we could be more assertive in a positive way. So like if you want to say no to somebody, you can say it very politely. So that way your interpersonal relationships are not affected, they're not hampered, and you're not compromising on your own self respect. So they, if you want your, like if you think your relationships have been affected because of the disorder, if the client is telling you that I don't feel accepted, I don't like anybody or something like that, so you can help them be more assertive, and accept people also the way they are. So you will learn to listen, communicate more effectively, deal with challenging people, and respect yourself and others. So you don't have to compromise on your self respect. At the same time, also communicate whatever you want to say, whatever you want to say to the other person. So that way your relationships are much better. Okay, stages of DBT. So a DBT has a procedure where you can follow, where in the beginning of the treatment, more serious, like suppose the person is going through a suicidal ideation, so that has to be addressed first, because those are going to be more harmful, right? So naturally, so issues such as self-injury or suicidal behaviors or ideation, so those have to be addressed first. So on priority basis, we handle the as a therapist, you can take up the more serious problem, thoughts which the client is going through. Then move on to address issues that affect a person's quality of life, because quality of life is, I think, what is most important, right? So if our quality of life is good, then there's nothing to really worry about. So if that is being hampered, compromised, then you need to use all these techniques. Interpersonal effectiveness, emotional regulation can be used, even mindfulness can be used to improve the quality of life of the client. So once the person has got over the self harm thoughts, issues, then you could go to improving the quality of life of the client. The next step is to focus on issues related to self esteem. Then you can work on the self esteem, like what are the things which a person would like to do, which would make him feel good. So main thing is, like, satisfy you. If you are satisfied as with what you're doing, your content, then you're happy, then your self-esteem is better. So then you once your self is you feeling good about yourself, you have a better relationship with other people. So it's very important for the therapist to also focus on self-esteem of the person. So that's the third thing. Then at the end, you can help the client go to the next level, where the person can have better experiences, healthier ways, maybe more of reflection, self actualization, to maybe get more satisfaction from what they're doing, and then pursue their life goals. So these are the different stages in which you could practice DBT on the client. Okay, now since we're done with the four components of DBT, we'll see how we can apply this in case of OCD, obsessive compulsive disorder. So first of all, what is OCD? What happens is, in OCD, one is obsession. So obsessions is about the thoughts you're going on thinking about certain things. Compulsions is more to do with the actions. Obsessions is more to do with the thoughts. So in OCD, the patient, or the person usually goes through a continuously thinking about one thing. Like they're very this thing. They could be too conscious about cleanliness, so they keep washing their hands. They feel that there are the germs on and they're everywhere, so they keep washing everything. Or they could be hoarding as another thing. Like they like to have things and not give away. That's another obsession. Then they could be obsessed about their health. They could be obsessed about safety of their family. The thought could be anything, which is actually coming out of a lot of fear attached to it. So that's OCD obsessions. Of the obsession part of OCD compulsion is because they're obsessed. They keep doing certain things, which become a compulsion. They have to do it. Like they keep washing their hands and washing everything. Keep cleaning everything, checking doors, checking their stuff, whatever their belongings are. Have this, am I carrying this, am I carrying that, am I saying. There could be some rituals which they go on following, because they feel if they don't do it, something wrong might happen. So it's basically an obsessive thought about something. And so it becomes so much that they go through a lot of anxiety and stress because of the compulsive thoughts and actions. So it's basically repetition of whatever they're doing. So there's a lot of overdoing of things. So how do we help a patient with OCD? The first thing in coping with OCD is being aware. You need to get the person aware of the obsession, that slowly, gradually, because they might be in denial that no, I have to do this, and I'm not overdoing it. So no, they may not agree initially, but then slowly you have to show them that whatever they're doing is not helping them. Like if they're obsessing too much about their health, it is only going to get worse for them, right? So because stress is always counterproductive. So if you're going to go on thinking, why am I'm not feeling well, I'm not, this is not happening, that is not happening. So what happens is then you're only uh, in spoiling, because your blood pressure might go up, your sugar levels might go up. So stress is one of the main causes of even physical illness. Now even the doctors are saying that. So so stress is in any ways not good. So first of all, you have to help the client accept this is the condition, you're overdoing certain things. So once the person is aware, then we can help them bring it down through many methods. So once the person is aware and able to accept, we can help them cope by suggesting activities to divert and engage them, which will help them distress and get a positive outlook. So you can slowly suggest activities which will de-stress them, like with whatever they could be interested in. Like it could be reading, it could be gardening, it could be doing puzzles, watching TV for some time, listening to soothing music. So there are many activities which you could suggest to the client, whichever suits them, whichever works for them. So these activities are used to either distract or self-soothe when faced with disturbing thoughts and emotions. So these are the techniques, activities which could help distress. So distress tolerance, this is how you could use distress tolerance in OCD. Like there's a picture here which says some for some people it could be having a warm drink that could soothe them. So aromatherapy could help, so or visuals could help. Sometimes massages could help. There are lots of things which are very self-soothing activities which you could suggest to your client, and it might work. Yes, mindfulness is a very good tool in OCD, because by practicing mindfulness, the client will learn to you know uh, keep focus on the present moment, whatever they're doing when they're doing the activities. So you help them focus only on that instead of thinking about other things which their obsessive thoughts. So they learn to be present and focus on the present activity. We can help them do that, so they can manage their anxiety or fear related to the obsession, which will gradually help them lessen the frequency. It might not happen overnight. It takes time. I mean, all these therapies do take time, as we know. We all know that. So, but gradually, but if it's done consistently, slowly the negative thoughts could be changed to more positive thinking. So you could, while they're doing whatever they're doing, you could help them focus on that. Emotion regulation. Now, this is a very important because the OCD especially, they go through a lot of emotions. They might be even conscious of their fear, but yet not be able to deal with it. And most many times the patient is aware that they are having, it comes a point where they understand, yes, I'm having this, but how to control. I mean, I cannot stop my thoughts. I cannot, completely ignore them. So that is the problem they go through, where they are not able to regulate their emotions. They are aware of their emotions, and very hard for them to regulate them. So in that, reappraisal strategies are very beneficial. Instead of, yeah, what sometimes, most times what happens is they sometimes try to suppress their emotions. They feel that, no, 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 I should not think about this, I should not think about this. But the more, like, suppose they've had a death in the family, there's been a death in the family, and a very close relative, and you're going on not able to get over it, not able to accept it, because it was not something which should have happened. So when such things happen for PTSD, uh, what happens when you try to, keep telling yourself, no, no, I mean, I will not think about it, I will try to not think about it. But then the more you're trying to suppress, maybe it keeps coming again and again. So suppressing sometimes may not be, a good idea, and it is counterproductive. It leads to more distress and intrusive thoughts. So suppression instead of suppression, reappraisal, means alternative thinking is what is should be suggested. So in interpretation of the stimulus to achieve a more positive, pleasant connotation. So you need to divert them into different other, topics, or other thoughts. You give them other scenarios in a different context. You can change the context for them, so that, something which they will like. So you need to suggest things which, of course, you need to know the client very well. So to do that, so that you can suggest other thoughts which they can focus on and which will be more positive for them. They will be able to forget the obsessive thoughts and get over that. So that is one thing. Then also distancing, visualizing the stimulus from perspective of an unrelated observer. So you can also suggest to them that you try to come out of the situation and look at yourself as a third person. As a third person, you look at yourself and analyze and reflect on what you're doing or what you're thinking. Does it make sense? You need to help them rationalize and, think. Let them think for themselves. What am I mean, are these positive thoughts or negative thoughts? So you will help them, understand the whole thing from a third person perspective. So you look at yourself only as another person. So it will help them come out of the situation and look at yourself. So OCD patients can reinterpret the intrusive thoughts as a common, and also take it as, also as an event that occurs in everyone's life. Like, also generalize it in a way, normalize it for them. Say, that could be one way of doing it. Not always, of course, But sometimes, if you tell them that, okay, if you're going through, suppose somebody's going through anxiety due to exams, or some presentation they have to do, so you can tell them that, see, that is very normal. Okay, everybody does go through this. So it brings down, I mean, it doesn't completely reduce it or remove it, but it will surely bring down the anxiety. Like when you see other people also going through the same thing, you start feeling less anxious about it. So that's one way of doing it. Then OCD patients can also distance themselves from the consequences by thinking of them as not real. Sometimes whatever fears they have, you can tell them that it may not even happen. Why are you getting scared? What you're thinking is like, I will get COVID or I will fall sick. If How do you know it's going to happen? So we're not sure. So why should we get scared of something which is not even going to happen? As much as there are chances of happening, there are enough chances of not happening, right? So you can make them look at it in that way by telling them that it may not be reality, it may not even manifest. So like you're worried about somebody, a loved one, something happening to them. Sometimes we do that. We get scared of somebody who's gone, who's traveling, or who's outside somewhere away from you. You tend to worry about those people as to what if something happens to them. How will they handle it? So we tend to worry about all other people also. That could become an obsession also. So then you tell them that, why are we worrying about something which is may not even happen? So it is not going to be a reality, may not be. So that's one way of looking at it. So also distraction is one way of managing emotions. Yes, there are many, like I said, you can distract them with giving other activities, like maybe doing something, art, cooking, whatever interests them. So that will surely, if done in a structured way, in a way which the client could understand. So of course you need to take the help of the family and the caregivers for this, because the patient may not do it on their own. So we will need help from the caregivers, so that you'll have to talk to them. In case of OCD, the caregivers and the family play a major role, because they are the ones who will actually be with the person, and will be helping the person. So it's very, very important that we involve the caregivers also. So it helps them divert their attention away from how they are feeling. So all these activities which I already mentioned, could be art, it could be biryani, it could be cooking, gardening, it could be physical exercise if they can do. I mean, if physically they can, that could be another thing, because it also gives, it also helps in positive this thing, chemicals and all that. So all that could help. Now, interpersonal effectiveness in OCD. In case of OCD, the most important are the caregivers and the family of the patient. They also go through the, kind of a lot of challenges, because it's difficult to tell the patient, help the patient explain that whatever you're doing, because you have to be very patient with them. Whatever you're doing is, going beyond a limit. They feel it is very normal for them. So they feel it is very normal for them. So but as an outsider, we can, as a caregiver, they can see that it is going beyond a point. So the caregivers also have to cope with the challenges of the behavior of the person. So so what happens is, the interpersonal relationship between the family and the person who's going through OCD is very, very important. So they play a major role. So and major role, because they are majorly affected. So the patient needs to be trained in accepting the condition, and then it becomes a little easier. Okay, then asserting their feelings. So help them talk about it. Help them tell express their feelings, express their feelings as much as, let them talk and express, so that it's also venting out. So you'll have to talk a lot. I mean, if they're left alone, the situation could get worse, the condition would worse. They should not be left alone. Especially patients with OCD, you should keep communicating with them. So the more you communicate, they will also be more assertive. They will express their needs, and it becomes easier for the caregiver and the person who's going through it. Questions I can take.
Thank you so much for that wonderful session on dialectical behavior therapy with the persons with OCD, ma'am. Thank you so much. And participants, if you have any questions, you
Did
can
I go
unmute
fast?
and no, ma'am. I think it was fine.
Ma'am, I have a question.
Yes.
This is Deepthi here.
Yeah.
Yes.
So a lot of, would you say that, any of these OCD symptoms, any of these kind of issues stem from a certain place? And is it therefore necessary to kind of understand that and help the client understand that from where it comes from?
Yes, ma'am. Yes. Actually, I've not mentioned the reasons, right? I mean, you're
Mm-hmm,
asking from where does it come? Yes. One is it could be genetic.
mm-hmm,
Okay, OCD is quite genetic, like any other disorder. If it is there in the family, to some extent also, there are high chances of, the children, or getting it. One thing is genetic. Another thing is the kind of person you are, like you have been brought up, in such a way that everything has to be perfect. Okay, so that could also lead to, this kind of a condition, where you've been, since childhood. Childhood, of course, makes a lot of difference how you've been brought up. And you've been told that everything has to be, in order, everything has to be perfect. Then that also impacts. So yes, but discussing the reasons with the patient is not necessary, not required, because then they might start blaming something else in the, like in the past. So that is not required. But yes, for us to know makes a difference. As a therapist, you can find out, whether it was there in the family, or how the childhood has been. That would help. That would help.
okay.
Did I answer your question, ma'am?
Yes, yes, you did.
Yeah.
Sorry, I do have another question if
Yes,
I
ma'am.
may.
Yeah.
Um, you just that if you can just explain the difference between dialectic
And
and cognitive again.
cognitive. Yeah,
Yes,
yeah, I'll,
please.
I'll get there. Yeah, I'll get there. See, in CBT, though I don't need the slide much, because I couldn't put everything on a slide. So in cognitive behavior therapy, what happens is, we're working on the negative thoughts. So you identify the thought process and beliefs also.
Yes,
To mention. Okay, there's a lot of, we have fixed beliefs about certain things. So
yes,
cognitive is more, we are focusing more on the, only on the thoughts,
yes.
not more on the action.
Mm-hmm,
Action we leave it to the client later. Okay, so we only focus mostly on the thought process. So we slowly, there's something called automatic thoughts which keep coming, which are negative.
mm-hmm,
So we replace the negative thoughts with positive, thoughts. How is, we first ask the client, okay, what are your thoughts? And now, what are the thoughts which you are getting in support of your negative thought? Like, suppose you believe
mm,
that I am not good at cooking,
mm,
suppose. Okay, and my family is not happy with me the way I'm
mm,
cooking. Okay, so you will ask the client that what are the thoughts which are supporting your belief.
mm,
Okay, then you will ask the client, what are the thoughts, now write down what are the thoughts which are not supporting the your thought,
mm,
belief. Like, suppose you have cooked, on certain occasions where
mm,
you have been appreciated also.
mm,
So maybe you tell the client, like, maybe you're good at something, you're not good at something, maybe
mm,
we're not good at everything, right?
mm,
So that's how you will change the thought process. So in
Right.
CBT, basically you're working on the thoughts,
Got. Yeah.
whereas in DBT it is more of, it's more the life, the way of life, the lifestyle, like how you're living. Focuses more on that and your relationships. To it's a more it's a very it's a better way. DBT is a better way because it's focusing on a lot of things, interpersonal relationships, distress, and the techniques are uh, better is what I feel. I mean, not
Okay.
that, but I mean, CBT is more useful used in anxiety and depression, works very well because it's mostly negative thinking in these things, in
Mm,
anxiety and depression, right?
mm, mm.
Whereas DBT can be applied to many more, and
Got it.
more so personality disorders.
Got it. Thank you, ma'am.
Yeah.
Thank you, Deepti ma'am. Ma'am, I have a question. The obsession, a person has an obsession, and then you have, based on that, he's going to act. He's going to either keep checking or
Correct.
cleaning. What are
Correct.
the other kind of compulsive acts that a person can have, ma'am, apart from cleaning and checking the locks and the
Locks.
gas fuel?
Yeah,
Yeah, yeah.
putting things in order. Nothing
Okay.
should be even this way, that way, like in fact, I thought, I used to think I had OCD because I was very particular about everything being in order. That's one thing. Then also attachment to things, belongings, your personal belongings. If you're too attached, that could also be a sign of OCD, where you don't want, you get very upset when, and you don't want to share, you don't want to give your things to anybody. Like sometimes we're so attached to our own, like old clothes, books. If that goes beyond the point where you just don't, I mean, you get very anxious when somebody wants it and you have to give it away. That could also be one of the things. So you're hoarding, whether you use it or not, you want to keep those things. It could be hoarding, it could be putting things in order. Like nothing should be out of place, all your things, nobody should touch them. All these things could also be coming under OCD.
Can we have obsession? The other question, thank you so much. Can
Yeah.
we have obsessions related to religion, ma'am? Something related to the culture and
Yes.
religious beliefs.
Yes. So yeah, to overdoing of that also is, yeah, it's coming under this, where you feel that if you don't do, something will happen, something wrong might happen to you. Going like being very very following something very strictly, and getting scared, of not doing. If you don't do, something will go wrong. If you believe that if I don't do the certain pujas, or don't follow certain rituals, something might happen, something wrong, something bad might happen to me. So that could be another obsession.
Thank you. Thank you, ma'am.
Welcome.
Yes, any other questions, ma'am? You can interact with the speaker,
Yes, yeah.
participant.
I think no other doubts, Anita.
Okay, okay, ma'am. Okay.
Devotee. Yeah,
Yeah. Yeah.
Mary,
Ma'am,
please go ahead.
I'm sorry. Can I please, if you,
Yeah, yeah.
yeah?
Yes.
Yeah, please.
Deepti again, ma'am. I have a client who has sort of self-diagnosed with OCD, and he has apparently also gone to a few psychologists at Manipal Hospital,
Okay.
and they have put him on medication for about 2 years, and then also taken him through counseling
Okay.
for those 2 years. So he's attended therapy and everything. Now
Okay.
all of this has worked for approximately about 8 9 months,
Okay.
and now he feels a remission.
Oh, okay.
Um, so obviously those therapists probably have tried all of these techniques, including medication, but it has
Okay.
obviously not helped him.
Okay.
So what would you think would be something that might help him? Huh?
See, if it's gone into remission, that means something has triggered. Must be some medication is suggested. in when it goes beyond the point
Yes.
where it is really affecting his daily life.
Yes.
Any of these things that they're affecting his daily life, and is not able, he's not able to function normally, not naturally, they will be put on medication. Along those, all the
Therapies. Yes.
therapies
Yes.
should be done, psychotherapies. Yeah, but if it's remission, then we'll have to see what was that event which triggered the remission, and maybe gradually again try different therapy, or maybe that diversion, distraction, all those activities which could be tried again. So
So long term, only management is by and large a
yes,
possibility, isn't it,
yeah,
ma'am?
you can only lessen the impact. I don't
Right.
think we can completely do away with it because it is a very
Right.
strong thing.
Right.
Yes, and also depends on the caregivers, the close
Mm-hmm.
people who are handling him.
Mm-hmm.
They have to be really patient because we have somebody in the family, so we know
Mm-hmm.
how it is.
Mm-hmm.
So you lot of patience. It's very difficult. In fact, it is more difficult for the
Mm-hmm.
people who are handling these patients more
People. Yeah.
than the patient himself or herself, because they are not aware so much of what all they are doing,
Right.
to the
Right.
extent they're impacting others also.
Mm-hmm.
It's very difficult for the person who's handling the person, like the
Got it.
caregiver. So maybe they could try different methods again, or medication. But has he stopped medication then?
Yeah,
Has he?
he was told to stop because,
Okay,
he had improved, so
okay,
he
but
had stopped it, but,
mm, but maybe he should
and he
go back.
doesn't really know of any trigger. That's the
Okay,
odd part.
not aware.
Yeah.
Maybe not
Yeah.
aware of what has happened, but
Mm, mm,
could be, there could be something which is has triggered the remission.
yeah. Yeah. Yeah.
There could be. Yeah.
Thank you, ma'am.
Yeah.
Thanks.
Yeah.
Thank you, Deepti. Thank you, ma'am, for handling QA.
We can
Yeah,
share the
Madeline.
PPT, ma'am. Somebody's asked for it. We can share the PPT. I'll share
Yeah,
it.
sure, ma'am. We can share.
Yeah.
You can forward to me. I
Yes.
will share in groups.
Yes, ma'am. We'll do that. We'll do that.
Yeah. Thank you, ma'am. Yeah, Marilyn, please go ahead for VVT.
Yes, Mrs. Kalyani, thank you so much on behalf of Deccan Positive Mental Health. This was a wonderful session. We've had session on DBT in the past and a few basics. And today also you have covered those basics, but also you have mentioned the application of DBT to OCD.
Yeah.
Now I'm sure like most of us have come across clients, or somebody in the family who has had, been diagnosed with OCD or who has gone undiagnosed but has symptoms. So you mentioned how you can use components of DPT to apply and reduce the distress that people with OCD feel. So you mentioned about distraction, distancing yourself from the situation, how we need to reappraise our thoughts, not suppress the thoughts, but reappraise it or reinterpret situations. And you mentioned a very wonderful thing, that is interpersonal effectiveness. Now we all know that people with mental health conditions experience distress, but even people around them experience more distress because they're dealing with that person day in day out. And this therapy DBT, actually, I'm pretty sure like people who are equipped with the skills and techniques are doing a wonderful job helping the families of these patients to help the person, support this person to overcome this, to overcome their obsessions, to help them with this anxiety that they're going through day in and day out. So thank you so much for this wonderful session, and I wish you all the best.
Bye,
She
friends.
got
Happy weekend.
disconnected, Kalyani.
Thank you. Thank you.
Bye, bye.
She got a power cut, it seems. That's why she had to leave.